Thank you. And thank you for inviting me. Before I start, I just want to say that if we can solve what happens in CFSME, it will have major advantages for the 10% of the population who are fatigued at any one point in time. So if we can understand what fatigue is, think of the efforts that we can make to improve that and how that could improve the British economy, because fatigue is extremely common. Okay, so how sound is the diagnosis in CFSME? It's very important, both from a clinical perspective and also from the research perspective. I'm sure most of you know about the CDC 1994 definition about the severe disabling fatigue and the fact that it must be present for at least 6 months and it affects physical and mental functioning for 50% of the time, etc., etc., etc. So I'm not going to go too much into detail about that. And I guess you also know that there are a variety of symptoms that affect people with ME, and I've just listed many of those here. And I'm sure that people who suffer this condition will have various sort of combinations of these symptoms, although it should be noted that the exacerbation of the fatigue by physical and mental exertion is common to everybody with this condition. And it is something that is so hard to explain. Why should physical and mental effort lead to a delayed worsening of the symptoms? Clearly, if you have, let's say, a heart or lung problem, then you feel immediately worse. Or if you have a mitochondrial problem, again, if it's just one of those inherited ones, you should expect an immediate worsening. So why is it delayed by such a long time interval? Sometimes it's a day or 2 days or 3 days. So why does that occur? And then there are various sort of exclusion criteria, and I've listed some of those here. We're all aware of these, and we take these into account when we are selecting patients for our research. And then there are temporary criteria, those that require evaluation over time, things like untreated hypothyroidism, diabetes, and active infection, and things that resolve, such as 3 months post-pregnancy or 6 months post-major surgery, and a few other things that are mentioned here. Morbid obesity, which unfortunately is becoming more frequent, and we are concerned that people who have very high BMIs will have particularly obstructive sleep apnea or frequent upper airway arousals and difficulties with sleeping. So we do take that into account. And then there are permanent exclusion criteria, particularly, these are the sort of psychiatric exclusion criteria, but it should be noted, particularly in regard to depression, that when you have an illness such as CFSME, which we can't explain fully, which causes a number of disabling symptoms, it would be unsurprising if at least some people did not suffer a low mood. And yet this is not the primary problem. So the low mood is nearly always secondary to the original illness. And so in my practice, when I see people who have CFSME, who fulfill the criteria that I'm going to show you in a second, according to the scoring scheme that we have, and these people do have underlying low mood, then I certainly try to ascertain whether the original illness, the CFSME, predated the depression. And also in some people where depression has occurred first, people are at pains to tell me that their present symptoms are unlike what they had with their depression. And they draw a distinction between them. And then there are the ME-ICC criteria, which are quite complex, actually, mentioning a whole lot of things. And then more recently, we have, this is just a touch of vodka to help me talk more fluently.
It's bad for you.
It's better than antibiotics. So systemic exertion intolerance disease, which is, I'm sure, something you've read about. Not a very catchy title. And the criteria are simple, perhaps a little bit too simple. And again, they mention the requirement for a substantial reduction or impairment in the ability to engage for 6 months. And note that the next major sort of requirement is this post-exertion malaise, which, as I said, is very, very hard to explain. And then unrefreshing sleep, And then at least one or two of the following manifestations also required: the cognitive impairment or orthostatic intolerance. And when we are looking at patients who have ME versus CFS, there has been this debate going on for a while, and people with ME obviously have the severe end of this, suppose it's chronic fatigue syndrome. But ME patients, as I said, they have a more consistent pattern and a significant post-exertion malaise. They have more neurocognitive dysfunction compared to those who simply have chronic fatigue syndrome, and the fatigue and the other symptoms are more frequent and severe in those who have ME. So to try and help GPs to make a more confident diagnosis and to make a referral more rapidly, we've developed, and this is something that we use in my service at the Sutton Hospital, a scoring system. And we've been using this now for the last sort of 5, 6, 7 years. And the reason for developing this is that it was very hard to find a medical person, particularly a consultant, to help me in my practice. And so what we needed to do was to get the nurses involved to see the patients and to help them come at the correct diagnosis. So this was developed at that point. And as I said, over the last 5, 6 years, it's proven very robust. And where I and the nurses have made a confident diagnosis of CFS, we have rarely had to revisit it. So very, very quickly going through it, the most important part of the scoring system is actually the loading for the various symptoms here. So that if you have a delayed post-exertion malaise after physical, mental, emotional exercise, and I'll say a little bit more about this in a second, then you get 3 points. And the importance of sleep and proper sleep is also indicated here by loading of 2. And then the other symptoms like the impaired concentration, the reduced short-term memory, the headaches, sore throats, joint pains, myalgia, they all get 1 point. But going through the whole scoring system, you will note that there is a maximum of 13 points. And for our clinical service, you need at least 8 out of 13 points. And everybody must have some form of post-exertion malaise, because that's a critical thing. In the vast majority of other medical conditions, we don't find this delayed post-exertion malaise. So that's why it's an absolute requirement, and that's why it's loaded with 3 points. But if we look at the delayed post-exertion malaise, then if you have a delay of over 12 hours after completing your mental or physical overactivity, and it's a prolonged duration of the extra fatigue, then you get 3 points. Whereas if you have an immediate but prolonged post-exertion malaise, that gives 2 points. And then if you have an immediate post-exertion malaise of less than 3 hours, then that gives 1 point. So we try and work out and categorize the different types of post-exertion malaise. And the most characteristic delayed prolonged post-exertion malaise gets the maximum 3 points. And then you've got the fatigue, the neurocognitive problems, myalgia, arthralgia, etc. They must cause significant disability for 50% of the time or more. And then going to the sleep disturbance and the non-restorative sleep, it must impact significantly on the fatigue to get the maximum 2 points, and it must be present for 5 days a week and persist with hypnotics. And then difficulty initiating sleep must be longer than 30 minutes, and the waking must occur more than once per night, and both must occur more than 5 days a week. And then the other sort of details about the sort of pattern of the sore throat and the neurocognitive dysfunction. So with all those factors taken into account, and with the additional ones, and particularly taking care, have I gone 2 slides forward? No. Okay. We take great care when we see patients who have a significant anxiety or depression. But remember, as I mentioned earlier, that depression and anxiety can complicate CFS and vice versa. But in our research, you've heard me mention that for our clinical work, you need to have at least 8 out of 13 points. But for our research work, we demand that all the patients entered into our studies should have 10 or more points. We want to be much more rigorous. And we use the HAD scale, the Hospital Anxiety Depression Scale, to work out whether there is significant anxiety or depression, whether we need to take that into account. Interestingly, there are 1 or 2 other things that we've noted over the years, and you've heard mentioned earlier that many patients with CFS have this hypersensitivity to medications, and particularly to the SSRIs, the SNRIs, and the tricyclic antidepressants. We don't know quite why that happens, and it may be that there's upregulation of various receptors, or there may be problems with the GI tract, or there may be the absorption or defects in serotonin. But it is something that we've noted frequently, and when we have to initiate some of these therapies in people who have CFS-ME, but with a complicating depression, then we routinely suggest to GPs that they start at 1/10 of the normal dose and then gradually increase. The other thing we've noted along the way of alcohol intolerance, which is very frequent. And in fact, I have seen very, very few patients who can tolerate 4 units of alcohol or more in a single sitting. Okay, that's good. Then from a clinical perspective, if we have somebody who has, let's say, scored 7 points, then we take these other things into account, and particularly in borderline cases, we look for cold peripheries, which my colleagues in Norway have also been very focused on, and suggesting that there may be problems with endothelial function in the peripheral vessel, causing a reduction in blood flow to these areas. But when I see patients with CFS-ME, and particularly during the autumn and winter, nearly all of them will come in, when you shake their hands are cold. And so we note that, and in addition to that, we note the effect of alcohol and the drug hypersensitivity. We've been doing a lot of work on pupil reflexes, and we're trying to develop an app which will allow us to measure this alteration in the pupillary reflexes. Normally what happens when people, neurologists in particular, shine a light into a person's eye, the pupil constricts. What we find in people with CFS-ME are 2 patterns. The more frequent one is when you shine the light, the pupil contracts normally, but then it dilates, and then it contracts and dilates, contracts and dilates. It goes on like that. That is present in probably about 85-90% of the CFS patients. But about 10%, there is a very paradoxical response. When you shine the light, the pupil constricts, and then it starts to dilate. Even when you shine the light, continue to shine the light into the eye. There's only one other condition where you find that, and that's autonomic neuropathy. And in that condition, you have antibodies to the ganglionic acetylcholine receptor. And yet, when we look for these antibodies in the CFS patients, we don't find it. But it's a very unusual finding that actually hasn't been written about in the medical literature. And yet, we do see it very, very frequently, and it can help us make the diagnosis. Now, in terms of the physical signs in CFS-ME, there are very few. Forgive me 1 second. And one of the things that we're noticing is that about 20% of our patients will have a joint hypermobility type problems, i.e. bendy joints with clicky joints and with stretch marks. And we're finding about 20% of our patients will have joint hypermobility. Quite often in the younger people, they'll be accompanied by their parents, and it's very interesting that the parents, well, at least one of the parents will have joint hypermobility as well. And we use the Bateman score to assess the presence of joint hypermobility, Ehlers-Danlos syndrome type 3. And I'm sure that people in the audience will say, yes, I mean, I have joint hypermobility, and my daughter's always been very, very flexible. She did ballet when she was younger. And so it is, again, something that hasn't been written about very frequently. And why people with joint hypermobility develop CFS is also very interesting. Now, perhaps I'll cover that a little bit later. We've also been looking at the respiratory rate, and what we're finding is that it is mildly increased in about 80% of our patients with CFS. It's not a big increase. It's probably only about 10-20%. But as you can imagine, if you are breathing 10 to 20% faster over a period of days and weeks and months, there will be changes that occur to your carbon dioxide levels in your blood, and slightly so to the pH. And these may be relevant in terms of producing some of the symptoms that we see. I've indicated there that the cold periphery is about 70%, and the altered reflexes in about 60%. So what are the conditions that can mimic CFS-ME? I've already mentioned the joint hypermobility, hypothyroidism, and a lot of the people that we see, they've done the internet search, and they'll say, but I have all the symptoms of hypothyroidism, or I have all the symptoms of Addison's disease with inadequate cortisol production. And then there are a smaller number who will ask about investigating any pituitary dysfunction. I had a head injury many years ago, and there's been recent work suggesting that one of the delayed effects of head injury can affect the pituitary. I'm going to talk a little bit about Addison's a bit later on in terms of our recent work on glucocorticoid resistance. But the other conditions that we try to look for in our patients with CFS-ME is underlying Sjogren's syndrome and early primary biliary cirrhosis. And the blood tests that we demand for patients referred to our service look for anti-nuclear antibodies and anti-mitochondrial antibodies. Probably in our experience, gluten sensitivity also comes into the differential diagnosis in about 1 to 2% of patients, and it's only when the GPs, because of our protocol, undertake the testing for the gluten sensitivity, they'll find that their patients have underlying celiac disease, which, as I'm sure you're aware, can be accompanied by marked and very debilitating fatigue. And then persistent anxiety and depression we look for, particularly using the HADS, but also questioning patients and primary sleep disorders. In my experience, over the years, we've also seen people with cardiac dysfunction, Parkinson's disease, and temporomandibular disorders. The point about differentiating CFS-ME from depression and anxieties is very important. And what we found, and I'm sure you appreciate this, that those people who have ME often, as I mentioned earlier, have an adverse reaction to antidepressants commenced in normal dosage. The sleep disturbances tends to be different in the people with ME compared to those who have depression, in that if you have ME, you find it difficult to wake in the morning, while those with depression have early morning wakening. These are just sort of very rough indication of what happens. And it's quite obvious that people with ME say that they can start a task, but they have difficulty finishing it. Contrast that with the situation those who have depression, who find it difficult to motivate themselves to initiate the task, but once they start it, they can often finish it. In my experience, once somebody has developed ME, it's very rare that they will resort to alcohol. And as I mentioned earlier, the majority of people with ME are hypersensitive to alcohol, to the point that there are some who will say, I only need to take a very small sip of wine or beer or something, it makes them feel unwell. But we don't know the mechanism for that. And as I'm sure you're aware, there are some people with depression who do resort to alcohol. Chronic anxiety is highly depleting of energy levels and contributes to faintness, impaired concentration, and it also increases the respiratory rate. So these are the basic panel of blood tests that we do. And before anybody is referred to our service, we make sure that all of these are normal. And then we can do an extended investigations where we think that somebody may have a connective tissue disorder. We'll look for anti-nuclear antibodies on HEP2 cells on some of our modern assay systems. If there's muscle tenderness, we'll look for the muscle enzymes and perhaps do an EMG, etc. And then if there's widespread aches in older patients, we'll look at the calcium, magnesium, and arrange a scan for underlying osteoporosis. The Addison's disease, Cushing's, we'll do a synacthyl or a dexamethasone suppression test. Do you think about past infection, and particularly Lyme's disease? That's hit the headlines quite a lot. It's very hard, and in this country, I'd have to say that Lyme's disease as a cause of CFS is much rarer than it is in some of the Scandinavian countries or in the USA, where the frequency of tick bites in certain states is not insignificant. But in this country, it's unusual to find people with CFS having had a prior tick bite and having lived in an area where there may be the appropriate types of deers and ticks. But you should be aware that the serology for detecting and diagnosing Lyme disease can be very hard to interpret. And we know that the IgM response can be positive even after full treatment. So I think you need to get expert advice on the interpretation of the Lyme serology. And then if patients have neurological abnormalities, we will arrange these further tests, and for sleep studies if there are sleep difficulties. And then there are highly specific investigations, which I'm sure many of you are aware of. We're not at the moment routinely doing NK cells, T cell subsets, etc., but in the research setting we have a great interest in these, and also in the cytokines and the other sort of proteins mentioned there. So I've talked a little bit about the story regarding spirochetes and Lyme disease, but quite often people will say that their illness started after viral infection, and is it worth checking for the Epstein-Barr virus or the cytomegalovirus, HHV6 and V7? At this stage, we don't tend to do that because we don't really have very good antiviral agents. Perhaps in the future, what we'll need to do is not only detect whether you've had evidence of infection, but actually look for the viral copy numbers. And then if we have the appropriate antiviral agents, we can then check to see whether the treatment with those agents will lead to a reduction in the number of the virus particles and see whether that correlates with improvement in symptoms. And in this country, at least in the UK, bacterial infections like Salmonella, Brucella, and Coxiella very hardly ever involved in causing CFS. Same goes with protozoa and fungi. There are, of course, immunizations, reports that HPV, influenza virus, and more recently, the human papillomavirus vaccine being followed by CFS-type symptoms and illness. So what about the other triggering factors? How far do we delve? There has been recent literature showing that life events and significant negative events are more likely to trigger mood disorder, but stress at the time of a triggering event may increase the chance of CFS-ME. And we look at this to see if when an individual developed the CFS and they had viral symptoms, was there a lot of stress going on that might impair the cellular immune system, which keeps viral infections under control? And if they've had a lot of stress and the cellular immune system is not working, then the viruses may disseminate widely and cause more mischief. And then I've said a little bit more about environmental toxins, and then the more recent literature about childhood traumas, physical, emotional, sexual, being present in a proportion of patients who then go on to develop CFS-ME. And yesterday we talked a little bit about how that may be involved in terms of the glucocorticoids and the steroids and how they can influence the development of the hippocampus and the amygdala. So this is my last slide. I'm going to spend a couple of minutes on this because it's very important. More vodka. Right. So the factors that will perpetuate chronic fatigue, I've tried to indicate on here. We know that disturbed sleep is very important. And if we can get that right, then that can not only, obviously, if your sleep is disturbed, you can feel tired during the daytime. But sleep is very, very important in memory function. So that if you have a correct pattern of sleep, all that you've done during the day is consolidate and things that you don't need are eliminated. So that has a significant impact on memory and concentration. And you will all know that people with CFS have this word-finding difficulty. So those higher mental processes are improved during the period of good quality natural sleep. So we do pay a lot of attention to try and correcting any sleep disturbance. We know that there is an immune dysfunction present in CFS-ME, and that the disturbed sleep interacts with the immune dysfunction, and probably the other way around as well. The immune dysfunction is very, very subtle. As an immunologist, what I see a lot of people who will have, let's say, antibody deficiency, who will have problems with their T cells and with their neutrophils, and they have a different pattern of infections. So in people with antibody deficiency, they have recurrent infections involving their chest and sinuses, and they'll have definite pneumonias. Whereas if you have a more subtle impairment of antibody production, you may just have recurrent bronchitis. But as I said, the immune dysfunction in CFS is very, very subtle, and we're only just beginning to work out what is going on. But linked with that is recurrent viral infections, and persistent viral infections, which have a negative impact on the immune dysfunction. The immune dysfunction has an impact on that. At the moment, we don't really have a means of correcting this. And as I'm sure you're aware, there is a little bit of controversy as to what are the precise immune defects that occur in CFS. And the most consistent abnormality appears to be impaired natural killer cell function. And Ian's just handed me a bit of paper about somebody who wanted to know about the link between ME and endometriosis. I have an interest in endometriosis, in which diminished NK cell function can also be found. So that may well be the link here. But trying to correct this impaired NK cell function at the moment is very, very difficult. We don't, as I said earlier, we don't have very good antiviral agents, but they will come along in time. And remember also that muscle dysfunction is important. And you've heard about the PACE trial, the fact that graded exercise therapy was helpful and that cognitive behavior therapy was helpful. I don't think we should ignore that, because I think muscle tissue is important not just for locomotion. We know that functioning muscle tissue, when it's normal, secretes endorphins, which can relieve pain, elevate mood, But importantly, muscle tissue also secretes brain-derived neurotrophic factor, which is very important for memory function and concentration. So, but it must be done by somebody who's experienced. We can't just sort of meet any physiotherapist or nurse or et cetera, or doctor who says, look, just get off your bed and do something. That's not right. It has to be done in a very, very understanding, sympathetic fashion. And then finally, we've been doing some work on endocrine dysfunction, the steroid and thyroxine peripheral resistance. This looks very, very interesting. And I think that there is a situation in people with CFS-ME who produce normal amounts of their stress hormones, the cortisol, but their peripheral, their body, their muscles, their joints, etc., just don't respond to it. And that might create a situation where they behave as if they've got Addison's disease with the fatigue, feeling faint on standing, etc. And stress also is very important, and the stress can be physical, mental, emotional, infective, and chemical, and it can contribute to increased adrenaline levels and respiratory rate. So in order to get better from CFS, you need to try and improve each of these areas. And I think that that's what future treatment should address, look at all the areas that are dysfunctional and try to produce therapies which will impact on each of these. So I'm going to leave it at that and take some questions.
Now, would you like to have some questions on that now? I'm sure there's a few queries and interests. Yes, the woman up there, near you, Pia, just close. Anyone else? Got it, nice. Okay, please.
First. I've been involved in the past with a lot of people who took part in a book, Investigate ME, produced. And recently I've been in contact with some of those people again, and a lot of them are people who became ill when they were children, and they are very ill. Many of them, very many of them, are deteriorating. And I find that a lot of them are completely housebound. They may be able to get to a GP, although a lot of them can't, but they certainly can't access any of the further investigations and tests that you mentioned. Is there any way that a CFS centre or that the NHS can help these young people who may have been ill for 20 years now?
Sure. Obviously, these people are distributed widely around the country. So on our website, the Epsom St Helier website, there are a number of documents that will allow GPs to undertake the appropriate tests. For instance, if there's a lot of muscle dysfunction going on, or if they think that there may be some sort of endocrine problem, or if there are features of a connective tissue disorder. So all the tests that need to be done are indicated on that. So they simply need to access that.
Okay, there's one over here. Nice.
But excuse me, they aren't tests that can be done at home, are they?
No. I mean, the blood can be taken at home, yes. And then taken to the local laboratory and it can be tested there.
Right.
But things like the EMG and obviously the imaging studies, they would have to be done in a major centre.
Yes, but it seems to me there's a lot of these, I don't know whether these people are even really adequately assessed that they have ME according to your criteria, which seems to me to be very good. But there seems to be this large pool of people who are just not being investigated in any way, either to check they've got ME or anything else.
How many centres are there like that would do this?
We usually started off with about 13.
Yes.
A few of them have had to close because of funding issues.
Right.
And a few of them have opened. So I think we're still down to about 13, actually. We're still about the same number.
Okay. Yes, nice.
Can I offer another physical sign, which at least in paediatrics I find very helpful? This is facial pallor. Can have a marked translucent quality to it. It's so distinctive that sometimes you suspect the diagnosis as the patient comes into the room.
Yes,
and when I've lectured paediatric ME support groups, I've looked down from the podium and you can see the white faces of the index children scattered among the audience. It may be that all your adult patients don't have it, or that they wear better makeup.
It may be the case. And as I look down from here, I can see that the people with the pale faces are the ones who attended the dinner yesterday and then went to the pub.
Yes, sir. Here's one here.
I started off life as a country doctor.
Yes.
And,
Richard, could you bring a mic over? Thanks.
Hold it like that.
in 1986, I had 30 patients who became severely ill.
Right.
and there was no doubt about it. They were all due to enterovirus Coxsackie B, which there was a pandemic at that time.
Yeah.
When I look back at them and the 2,000 patients that I've seen in a ME/CFS clinic,
Right.
the physical signs, I agree with some of them you're saying, but there's an awful lot more when they're examined sort of 5 minutes after doing some sort of exercise.
Totally agree with you.
There's a positive Romberg, there's extrapyramidal signs, there's cogwheeling, and pronator sign, which I'm sure you'll do, and a converse Argyll-Robertson pupil.
Yes, I heard that mentioned.
Yes.
Yes, I can't remember who drew my attention. Yes, that's an interesting one. I haven't found that, but we are doing more work on the pupillary reflexes, which may be a very useful bedside test and in general practice.
Yes. I find the main problem today is that myalgic encephalomyelitis, it was known in the 1940s up to the 1970s, has been submerged by psychiatric opinion, and the causation has been buried, and we're just examining the effects.
No, I agree with you. And you're right. I mean, assessing the patients after they've undertaken any physical exertion, 5 minutes, 10 minutes, or the following day, actually gives you a very high pickup rate in confirming the diagnosis. But the criteria that I've highlighted here is really to help general practitioners to make a confident diagnosis and get an early referral.
Yeah. And I noticed that sort of 20% of the patients are psychiatric. So it's a good idea to watch them getting out of the car, in the car park, walking up to the consulting room, and when you've examined them, watching them get back into the car again.
Yeah.
They're different people.
Yeah.
One more? Yes, there's two more up there. Yes, please.
Yes, just to add on the clinical signs, maybe in Finland it's maybe more relevant than other countries, but people used to go to sauna once a week and they cannot tolerate anymore going to sauna. So that's a very typical sign.
Yeah.
Okay, and the woman behind you?
Hi, hello. I noticed on your chart you were showing the possibility of ME-like symptoms being triggered by vaccinations. You mentioned the HPV vaccine, and my daughter's developed the ME-like symptoms and POTS-like symptoms after having the HPV vaccine in 2010, and she's still ill now.
Yes.
So that's age 12. And what her description of it is that after she'd had post-viral fatigue when she was 9, and had got better, we thought, and was back to normal again, and then was given the first of the HPV vaccine jabs. Yeah. And she now tells me, she's only 12 at the time, but that she felt her energy instantly depleting, and then she had the second one, and then developed ME. She had very severe side effects to both the first and the second jabs, which now is an acknowledged yellow card, should have been submitted. But what I'm interested in, I'm connected with lots of families around the UK who this has happened to their daughters. Are you planning to do any research? Because it seems to be quite a distinct group of, it may not be large, but it's a distinct group of girls that have developed these symptoms, and it may be an interesting area for research as to what happened to them and why that caused those symptoms in them.
Yes. I mean, I know that Scandinavian colleagues are very interested in this, and that at least one centre has probably gathered details on about 100 girls who've had a similar sort of illness after the HPV, Gardasil in particular. So we'll try and link with them and to see where we need to go from this. But it would be a fruitful area of research, you're right.
Thank you very, very much.